Now we come to another very special presentation, and that is our annual Dr. Steve Coutré Chronic Lymphocytic Leukemia Memorial Lecture. And as those of you who have attended previous meetings know that we instituted this lectureship a few years ago following the loss of Dr. Coutré to honor his memory, honor his illustrious career, his many contributions to the advancement of the treatment of patients with CLL, and also very much his friendship, his support of this meeting. I have to say personally, I think many people here would agree with me, probably in these past 22 years, the most impactful lecture that we have heard was that given by Dr. Coutré, and one that I know each of us will never forget. We're very, very pleased to have as our lecturer this year Dr. John Byrd from the University of Cincinnati. But we also have another very, very special guest that we're just so pleased to have with us, and that's Mrs. Kathy Coutré, Steve's wife. And she is gracious enough to honor us with her presence and is willing to come up and share a few thoughts with everyone here.
Thank you, Dr. Hyman, and thank you, Dr. Byrd, for having me. I'm honored to be here, and more honored that you have set up this lecture series in memory of my husband, Steve. He would be absolutely thrilled, and I know you will keep his memory alive, and that's the most important thing for me. So I just want to thank you all for having this lecture series. Congratulations.
Thank you.
Yes.
Thank you, Mrs. Coutré. It is customary at this time that we present our lecturer with a special medallion that has the image of Dr. Coutré on his picture to both honor the lecture and honor Dr. Coutré's memory. And Mrs. Coutré would like you to have one as well.
Thank you.
Thank you.
Go ahead. I'm going to get tearful. So it's quite an honor to, first of all, to see Kathy again. And she probably won't remember the last time we were together. And I'll remind her. So thank you for choosing me to give this lecture. And the memory I have best of Steve are two things. So those of you, we heard a wonderful talk about empathy. And I had the honor of seeing a number of Steve's patients when the BTK inhibitors were coming in, and he didn't have, he didn't have a trial open, and we did. And his patients would fly from California, from Stanford to OSU, where I was at then. And all of his patients talked about Steve's consummate bedside, I say bedside, but it was clinic-side manner. He always looked them in the eye. He always was empathetic. He carried their interest in their best need. The patients weren't for the trials were for the patients, and it was phenomenal in that manner. But he was also, the Renaissance man. I love that description, because the best memory I have of Steve is when Campath, or alemtuzumab, the branding meeting, occurred, and we were together at that. And Kathy, I think that's the last time we were together. And what was amazing is Steve had a phenomenal ability to find great wines. And we were at a wine, say after the branding, we got to drink lots of wine in Napa Valley, including cake bread, which is still my favorite wine. And I would recommend. I don't have a conflict of interest of having stock in their winery, but I would recommend, if you haven't tried cake bread Merlot, you try it. So, thank you. And what I'm going to try to do I can figure out how to use this, in the next 20 minutes. Has the clock started yet? How many minutes do I have? All right. Well, I always wanted to be a fireman, so at least I'm gonna get to hear the fireman's siren. So, what I want to do is talk about relapsed and refractory CLL and approach it as I think about it in the clinic. So this is going to be a sort of a different type of lecture. And really, as we think of relapsed and refractory CLL that we're seeing now, we have to think of really 4 classes: those who have not seen anything other than chemoimmunotherapy or chemotherapy, those that have only seen a targeted therapy with a covalent BTK inhibitor, those who have seen venetoclax plus a CD20 antibody, most often obinutuzumab, and those that are double refractory. And when I'm seeing that patient, after getting their history and sort of seeing where they're at, the evaluation really for all of these patients, this fission and stimulated karyotype, NGS, including P53 and clonal hematopoiesis genes, particularly if the patient is anemic. And if the patient's anemic, I also do a bone marrow, because often, particularly in the chemotherapy patients, you can find that they have clonal hematopoiesis. And really, this category of chemotherapy treated alone is very, very, very uncommon at this point, because we're well into the targeted therapy era, unless it's an IGVH mutated patient, where, again, as Dr. Teferi says, you have to be sure you don't do something to hurt those patients, because those patients are going to do very well. Again, the same evaluation approach. And for this patient group, I sort of think of this patient group as an untreated patient almost. Say most of them have gone a decade or more without therapy, or at least 5 or 6 years. They have low-risk disease. And I take the same approach that Dr. Weck outlined. I don't give, rather than telling you my preference, I'll say I avoid second-generation BTK inhibitors if they need warfarin, or they have a primary bleeding disorder like von Willebrand's disease. And I avoid venetoclax if they have a P53 mutation or clonal hematopoiesis. One thing Dr. Weck didn't allude to is that venetoclax can accelerate clonal hematopoiesis, and that's sort of why I use that to discriminate, particularly if they have a complex clonal hematopoiesis abnormality. That second patient group, which, depending upon geographically where you're at, when I was in Columbus, this was a much more common. In Cincinnati, the doctors tend to use venetoclax obinutuzumab first. So, but for the patient who's only had a covalent BTK inhibitor, and I look at this, I look at this patient and think, is this progression or is this intolerance? If it's progression, and they progress within less than a year, it's virtually always, I think I've seen one case in my career that progresses in a shorter time period than that. It's almost always something else. And sometimes it's a challenge of figuring that out. Or the patient is not being compliant with the medicine. And we go through the same algorithm that Dr. Larson talked about with CML. If it's between 1 to 2 years, it's probably CLL, but it can also be something else, but less likely. And the longer you get out, the less likely it is. And if it's intolerance, then it's almost always CLL. So if the patient sort of is on and off, they're intolerant. And again, here, how I approach this is, say, if I suspect Richter's, we do a PET scan, it can go after that site. We do the same FISH, but we also look at mutation of P53, BTK, PLC gamma 2, and our clonal hematopoiesis genes. And again, the bone marrow biopsy is say if they have cytopenias, looking for MDS, or the like. And here, for that patient that's only had the chronic BTK inhibitor, the covalent BTK inhibitor, and is intolerant, if they don't have a BTK mutation or a PLC gamma 2 mutation, they've got acalabrutinib, they get zanubrutinib. Zanubrutinib, acalabrutinib. Data with both that you can often get rid of the side effects. If they're intolerant, or have progressive disease on a covalent BTK inhibitor, then here's where the genomics of studying BTK and PLC gamma 2 come in, because if the patients have the 41S, which is the most common BTK mutation, I like to stay in class with pirtobrutinib. That's not exactly where it's approved, but again, learning from CML, that staying in class is the path that's done. We want to follow the path of CML, and it's also a lot easier than venetoclax. Trials are very important, and venetoclax and a CD20 antibody is also an alternative, but it's probably my second alternative in this setting. They have a gatekeeper mutation, then it's a trial. A gatekeeper mutation or a PLC gamma 2 mutation, then it's a trial, or going on to venetoclax obinutuzumab. I like to stay in the same class of drugs, because particularly if something's working, that tells you the cancer is still addicted to it. And so rather than changing class, I like to stay in the same class. How about if the patient has only received a targeted therapy, with venetoclax CD20? And here, the time is important. So if they progress within a year, it's also virtually something else. It's not Richter's, Hodgkin's disease, even another cancer, if it's an isolated node. If it's more than 2 years, it's more likely to be CLL, particularly if you see a lymphocytosis. And here again, the PET scan, I check if they've had a BTK inhibitor before, we would do that. And the approach that we would take with this group is that if the response has been greater than 2 years, they don't have a BCL2 mutation. And again, that had BTK, PLC gamma 2. I always look for BCL2 mutations. And they don't have clonal hematopoiesis, then I really would consider giving that therapy again. The Murano data shows that you see good responses, 75%. That was shown by a nice paper from Anthony Mato as well that showed a 79%. The progression-free survival is going to probably be shorter, just like with chemotherapy. But that would be the approach. For patients who have a shorter than 2-year, 2-year remission, those that have a BCL2 mutation, or that have clonal hematopoiesis, I would use a second-generation BTK inhibitor. There's data from, it's from the Australian group showing, again, in a small group of patients, you see a 91% response, 34-month progression-free survival, and this is an approach that we've taken for a long time. Now, here's an important point that I want to make. What about the patients who have seen a covalent BTK inhibitor and venetoclax, plus or minus a CD20 antibody? Again, really, really important to differentiate, if these were given concurrently or sequential. If they're given concurrently, we really don't understand what the resistant pattern of that is. It's not very common. And when both agents have been given sequentially and then you truly have a relapse, you really need to involve a CLL specialist, because those patients progress quickly, die, and the best option at that point, while you can manage them in your practice, they're very challenging. Diagnostically, again, this group often, you'll be ruling out Richter's with a PET scan, doing your sequencing, and doing your HLA typing and asking a transplant physician to see the patient. How do I approach these patients? Again, if they don't have a BTK mutation or a CIS41S mutation, then I'll consider pirtobrutinib, ibrutinib plus lysocil, so, or CAR T cells, or an alternative BTK degrader, say inhibitor. They have a 474I, again, the same thing, 2 therapies that we have approved, say with permutation or a clinical trial. If they have an alternative BTK mutation or PLC gamma 2 mutation, again, looking at trials, and an important point, if you see this A428D mutation in BTK, say the BTK inhibitors, including pirtobrutinib, are not going to work. So what supports the recommendation to do that? Well, first of all, the Byrd study now is a phase 3 study that compared pirtobrutinib versus idelalisib rituximab or bendamustine rituximab in patients with double refractory disease. And this shows the demographics of the patients, multinational study. And there's a fair representation of different BTK and PLC gamma 2 mutations. And this slide summarizes the outcome. Again, say pirtobrutinib beat the pants off of the control, 15.3 months versus 9.2 months. Survival, we're probably too early as of yet, and there was the opportunity to crossover. This was a very safe drug. We know this because it was approved in this indication in an accelerated manner. Most patients don't know they're on a medicine when they're taking this. And so my conclusions from this study, that's right, it shouldn't have been done, because we knew this was a great drug from the initial phase 2, and a lot of patients received therapy that wasn't appropriate. Bendamustine rituximab is not appropriate in P53 mutated patients, and we don't use idelalisib rituximab. And hopefully the FDA is going to hopefully move away from making us do studies like this. It is a very good drug. It's important to recognize, though, that mutations occur in patients, on pirtobrutinib, and one can still stay in this class with degraders or LP168 unless it's that A428D mutation. That's almost like the T315 gatekeeper mutation in CML, although it's for a different reason. All the drugs can't bind to that particular mutation to BTK. So why would we use ibrutinib with lysocil? Well, at ASH this year, there was a nice update of the Transcend CLL-04 study that was the initial study that led to the accelerated approval of this, and there was a cohort in this where they gave ibrutinib. And again, these were double refractory patients, typical lysocil, and the approval for this, the CLL doctors, there's not a lot of excitement for this, because by itself the progression-free survival was not good. Most patients relapse within the first 2 years. So again, demographics, very heavily pretreated group of patients, and what was remarkable about adding ibrutinib to this is the CR/CRI rate was 45%. That's double what was seen with lysocil alone. And CR at 30 days after CAR T cells is a very, very big predictor of long-term remission. And we won't use the cure word, but I think a subset of patients are going to be cured with this. Again, one can see this, that the progression-free survival for patients who had attained a CR was extended, and since ibrutinib is approved for CLL. Lysocil is approved for CLL. Why not give our patients the best chance of getting the best out of this? And so if I'm taking a patient to transplant with lysocil, or if I'm doing lysocil, given it has modest activity, say the ibrutinib addition didn't appear to add morbidity, and I think using this in the context of CAR T-cell is worthwhile. The question will be, will second-generation BTK inhibitors have this effect? That's to be determined. So I talked about degraders as a therapy, and let me introduce NX-5948, which was presented at ASH, and this is in the dose escalation portion, but again, when we look at the patients, very heavily pretreated with all of the BTK and PLC gamma 2 mutations that we see in this patient population. And of 49 patients, the objective response rate that was presented was 75%. These responses have been durable, although patients do relapse on this, but we're just starting to see that now in patients that are out more than a year and a half. Very well tolerated, a profile similar to what's seen with the other BTK inhibitors, except maybe a tiny bit more bruising. That would be my clinical observation. So this study goes on; it's moving to phase 2, and there are other, there are other agents, other degraders, that I'll allude to at the end. The last trial, and something that's really exciting, that we heard about with the lymphoma data, is epcoritamab, and say this was presented at ASH, and again in patients who are highly refractory. They looked both at an expansion cohort where they gave it the same traditional step up like you do in lymphoma, and then they added an additional dose in the optimization to try to diminish CRS. And again, when you look at the demographics of the patients on this, very, very heavily pretreated patients, 55% with 50 to 55% with p53 abnormalities. Say median number of therapies. Say very high, 4. So we don't see this in most of our other trials, and most patients were double refractory. Again, with this, what was seen was a fair amount of CRS and some neurotoxicity. But what's really amazing, and when you look at adding the extra dose of epcoritamab, the ICANS and grade 2 and grade 3 cytokine release went down considerably. So again, pointing, CLL is going to be a little bit different with these. Now here's what's exciting. This is really exciting. Double refractory patients, and they saw almost a 50% CR rate with this in the different groups. And a lot of these were MRD negative. And when we look at the progression-free survival of this study, again, 4 prior therapies, double refractory, the median progression-free survival you see, and the overall survival, again, follow-up is short, still very impressive. Now, this regimen has a fair amount of steroids. You could say, well, is this steroids? We don't know the answer. Here comes the bell. I'm waiting for it. Oh, 1 minute. Okay, good. How many minutes do I go to get the fire truck? All right. So why am I so excited about epcoritamab in this? So 50% CR. These patients had bulky disease often, and imagine if we get this into frontline therapy, say with better T cells, what this is going to do. And just like CAR T cell, say somebody else, I can't remember now because there's been so many smart people talking before me, made the comment about Ken Anderson, how potent the immune system is. And I believe these drugs are going to help us cure patients with CLL. So what did we not discuss? We didn't discuss the Beijing degrader, and they had similar data presented at ASH. There are several of these in the clinic. I didn't talk about LP168 or rilzabrutinib, which has significant activity in gatekeeper mutation CLL. Dr. Woyak presented this. And most importantly, Sar Gill's group at Penn presented that 79% of patients who remain in CR after CAR T-cell at a year, and again, this is why you need to get the CR, remain in remission at 6 years. So is this an early surrogate for cure? Thank you very much. I will request that I get to hear the fire, please. Victory.